Hi, Dr. Bowden. I'm coming to you from Illinois, where I'm here for a basketball game. Currently in the hotel lobby since I have a roommate. Um, so if you hear any noise, I'm pretty sure there's a cheerleading team here, so we will just have to go with it. This will be my Maitland versus Mulligan Technique comparison assignment. And I just want to say, it's very interesting for me to learn about them and compare them because I've really only learned Maitland. So I figured the best way to compare and contrast would be with a Venn diagram. Easy, simple, and something that I've used for years. So let's start first with the Mulligan technique, as you can see on the left side. It's often known as it's often used as a sustained passive glide or force while the patient actively performs a previously painful movement. And what that means is the clinician first finds a comparable sign. And then comparable signing meaning the sign that irritates it the most. So sometimes that would be like gripping or moving into extension or flexion, in any range of motion. It's performed only until the onset of pain or until the end range of motion. However, it can be used by having an overpressure. But basically that's happening is the clinician is going to have a sustained glide in a direction, and the patient is going to be doing that most irritating movement, but they should not feel any pain. If they do, the mobilizations are stopped immediately, but they're usually not done more than 10 times. It can be achieved with tape, and I guess the one thing that I think about with this is a Mulligan tape job, and that's for the knee, where you use a very sticky tape like a Leuco tape, and you pull the patellar into what basically is a sustained passive glide, and it keeps it in the groove. So that's really cool that it can be achieved with tape. It's most often performed in a weight-bearing exercise. So like we read over the article, an example of that would be a lunge with the knee trying to touch the wall, and you're looking at dorsiflexion range of motion. There is no grading system for force. They do use the PIL acronym, which is pain-free, instant effect, and long-lasting. So you want to have it in the pain-free range of motion. You want to have them pain-free. Usually has an instant effect, and its goal is to have a long-lasting effect as well. And it can be incorporated into a home exercise program, which I think is really, really cool, because if possible, a clinician can show a patient how to do this. It's something they can do at home, so they don't have to come into the clinic every day, which is awesome. Oh, excuse me, I jumped too quickly. When I looked at the Maitland now, Maitland is what I learned. It involves 3 concepts: oscillation, sustained, translatory, joint play, and manipulations. It is performed non-weight bearing most often. However, I've seen it in my clinic being used with weight bearing, but I learned it originally, and what I've seen in the article, that it's going to be non-weight bearing. You want to have them in that relaxed position. And it has grades 1 through 5, so 1 being pain-free, and then getting up to grade 5, which is actually not, it has to take a very experienced clinician to do so. It's often a velocity thrust. It does utilize the concave and convex rule, which I think is really cool. And what I learned about it is, or what I learned on how to remember it, is if you're trying to mobilize the concave surface, meaning the surface that, well, looks like a cave, so it has that indent or has the fossa, and you're going to be using the same direction, so concave with a big A, same direction with a big A. Now if you're mobilizing the convex surface, so the flat surface of the surface that does not have the dip in it, it's going to be moving in the opposite direction. It also uses traction. So traction is a very important part. You want to put it in that relaxed resting position as you see below that bullet point. And then that's always where you start, in the place that has the least amount of force and pressure on the joint. So, but you don't see that in Mulligan. So those are the 2 things, those are the couple of things that stand out to me. So if we look at these techniques, we see on the left is Mulligan. So what's happening is the clinician is providing a forceful, sustained glide in this, on the elbow here, and while the patient is having the gripping exercise, which is the same example I used earlier. And if you see the Maitland is pulling the traction out of the shoulder for this example and pulling down to do a posterior glide. So those are going to be oscillations. Now, if we look at the similarities right here in the excuse me, the center of the Venn diagram, you see that both are applied parallel to the treatment plane. It can be performed with hands or a belt, which can definitely decrease the strain on the body, especially if you're a small person working with a very large foot or a large shoulder or a large hip. Improvement should always be measured with a clinical assessment tool, so a goniometer, a dynamometer, or a patient-rated outcome scale. Really the only things that can be used to track progress, especially when they're so hard to, like if it's pain, it's hard to measure pain sometimes. Either of these can be applied in different directions, so anterior, posterior, lateral, medial, and often sometimes rotational. It's indicated for decreasing pain and increasing range of motion. Both of these are often used for those types of results. It does involve the osteokinematic and arthrokinematic motion, so the joint motion and then the physiological motion, or the what the bone is actually doing. And what I found interesting is, perhaps I have this wrong or misunderstanding, but Maitland's sustained transipsoid joint play is similar to Mulligan's with movement, in that you are using force to move it in a specific direction. However, with movement you're going to use that comparable sign. So I looked up a little research on Maitland versus Mulligan, and I found a really great article about nonspecific neck pain, which is something that I haven't really dealt with, but I do have, just because of my population. I'm in younger individuals, and it's not normally something you see in teenage or young adult populations. However, it can certainly happen. So I looked at Guatman et al. Comparison of Maitland and Mulligan mobilizations and improving neck pain, range of motion, and disability. It's in the International Journal of Physiotherapy and Research. So the methods is they had 3 groups, and they performed these exercises 4 times a week for 30 days, and pain and range of motion were assessed on day 15 and day 30. Group A was a placebo, so they did active exercises, isometrics, and moist hot packs. The second was a Maitland. They did grade 2 oscillations for 60 seconds with 223 hertz, not 203 hertz. That would be quite a lot, so that's a typo on my end, 223 hertz. And finally, Mulligan was the third group, and they used NAGs, 223 hertz for less than 6 repetitions, and SNAGs, 3 sets of 6 repetitions. Now, the results indicated that both the control group and the Maitland group showed decreases in pain and disability, which is very cool because that's what I learned. So I like to see that in a peer-reviewed article, that it definitely supported that. However, only the this is another typo. Only the Mulligan group showed decreases in disability, pain, and increases in range of motion. So I apologize for that. Another typo here. I did proofread. Interesting. I just missed these. Only the Mulligan. Now, the Mulligan group shows decreases in disability, pain, and increases in range of motion. So that's the interesting thing about this result, is that the Mulligan was the only one to increase range of motion. Now, when I look at the clinical bottom line, it says Mulligan may be more beneficial in patients who have the range of motion as a large concern, with a secondary benefit of reducing pain and disability in individuals with nonspecific neck pain. So that's what this article said when you compare them. They had some support in this article as well, but results, of course, should be taken clinical experience into it, because, of course, for different areas of the body. However, what I see here is, and what's consistent with some other articles I've read, is that the Mulligan is going to have that range of motion benefit, and it's going to have that immediate results, whereas joint mobs often, while you're doing them, do provide pain relief. However, a lot of the times in a regular joint mob, for Maitland's joint mobs, you're going to see that result much, much later, when the range of motion is taken over time. Anyway, so this was my work cited. Found it very interesting to learn about these different techniques, especially the Mulligan technique, and I look forward to using it, since I have a couple of athletes that I think could definitely benefit from this. So very cool to read about, and very interesting to compare and contrast. Thanks, Dr. Powden.